Welcome to Pediatric Case Review. Today, we present a comprehensive case-based review of X-Linked Adrenoleukodystrophy designed for general pediatricians in active clinical practice. X-Linked Adrenoleukodystrophy is a paroxysomal disorder that combines progressive neurological disease with adrenal insufficiency, and recognizing it early can be life-saving. Across this lecture, we will work through 16 carefully constructed clinical cases. We will cover clinical presentation, the underlying genetics and pathophysiology, newborn screening, neuroimaging, the adult phenotype, differential diagnosis, dietary and advanced therapies, endocrine management, surveillance, inheritance, and prognosis. Let us get into it. Case 1. A 7-year-old boy presents with declining school performance, new-onset visual impairment, and behavioral changes with irritability. Brain magnetic resonance imaging shows symmetric parieto-occipital white matter lesions. What is the most likely diagnosis? Option A, multiple sclerosis. Option B, metachromatic leukodystrophy. Option C, childhood cerebral adrenoleukodystrophy. Option D, acute disseminated encephalomyelitis. Consider the age, the behavioral and visual decline, and the symmetric posterior white matter pattern on imaging. The correct answer is option C, childhood cerebral adrenoleukodystrophy. This is the most severe and most common childhood phenotype of X-linked adrenoleukodystrophy. The age of onset is typically between 4 and 8 years. The first signs are usually behavioral change and a decline in school performance. The disease then progresses through visual loss and seizures toward a vegetative state, and significant disability develops within 6 months to 2 years. Importantly, around 90% of these children already have adrenal insufficiency at the time of diagnosis. One key teaching point: this cerebral form essentially never presents before the age of 2.5 years. Case 2. A 5-year-old boy presents with progressive skin darkening, intense salt craving, and persistent fatigue. His morning cortisol is critically low. The family history is striking. An older brother died of early neurological deterioration. The question to consider is this: what is the most appropriate initial diagnostic step? Think about the combination of primary adrenal insufficiency in a young boy together with that family history of a brother with neurological decline. The most appropriate initial diagnostic step is to measure plasma very long-chain fatty acids. Adrenal insufficiency is very often the first sign of X-linked adrenoleukodystrophy, sometimes appearing years before any neurological symptoms. Plasma very long-chain fatty acids are the essential initial biochemical test, and this test is essentially 100% sensitive in affected males. The diagnostic pattern is an elevated C26 fatty acid level together with an elevated ratio of the C26 to the C22 fatty acid. So in any boy with unexplained primary adrenal insufficiency, especially with a suggestive family history, very long-chain fatty acids should be checked. Case 3. A 6-year-old boy presents with progressive behavioral changes, skin darkening, and difficulty walking. His mother reports that he was previously healthy. Which combination of findings is most consistent with X-linked adrenoleukodystrophy? Option A, hyperpigmentation, spastic gait, and behavioral regression. Option B, jaundice, hepatomegaly, and seizures. Option C, macrocephaly, hypotonia, and a cherry red spot. Option D, vitiligo, cerebellar ataxia, and optic atrophy. Think about how the adrenal, the neurological, and the motor features come together in this disease. The correct answer is option A, hyperpigmentation, spastic gait, and behavioral regression. This triad reflects the 3 core domains of the disease. The skin darkening is a diffuse hyperpigmentation, especially noticeable in the skin creases and the lining of the mouth, and it reflects the underlying adrenal insufficiency. The upper motor neuron signs include spasticity, brisk reflexes, and an extensor plantar response. Visual field deficits, such as a homonymous hemianopia, arise from involvement of the occipital region. When you see this triad in a school-aged boy, you should suspect X-linked adrenoleukodystrophy until proven otherwise. Case 4. A 6-year-old boy is newly diagnosed with X-linked adrenoleukodystrophy. His mother asks what causes the disease. Which option best describes the primary biochemical consequence of the ABCD1 gene mutation? Option A, impaired transport of very long-chain fatty acids into peroxisomes. Option B, defective mitochondrial fatty acid oxidation. Option C, reduced cortisol synthesis in the adrenal medulla. Option D, abnormal myelin basic protein production. Recall what the ABCD1 gene actually encodes and where its protein product does its work. The correct answer is option A, impaired transport of very long-chain fatty acids into peroxisomes. The ABCD1 gene, located on the X chromosome, encodes a peroxisomal membrane transporter protein. When this transporter is defective, very long-chain fatty acids cannot enter the peroxisome to undergo beta-oxidation, so they accumulate. These fatty acids build up in the plasma, the adrenal cortex, and the central nervous system. Their accumulation destabilizes cell membranes, which leads to death of oligodendrocytes and adrenal cells. One important point, there is no genotype to phenotype correlation, so the very same mutation can produce very different disease severity, even within one family. Case 5. A 6-year-old boy with confirmed X-linked adrenoleukodystrophy has a normal neurological examination today. His pediatrician asks a thoughtful question. Why do very long-chain fatty acids accumulate preferentially in the brain white matter and the adrenal cortex, and not equally in all tissues? Which two cell types are most vulnerable to very long-chain fatty acid accumulation because of their high lipid turnover? Option A, oligodendrocytes and adrenocortical cells. Option B, hepatocytes and skeletal muscle cells. Option C, renal tubular cells and astrocytes. Option D, Schwann cells and pancreatic beta cells. Think about which cells are most dependent on continuous lipid membrane synthesis. The correct answer is option A, oligodendrocytes and adrenocortical cells. Both of these cell types share a very high rate of lipid turnover, and that is exactly what makes them uniquely vulnerable. Oligodendrocytes are responsible for synthesizing and maintaining myelin, so the accumulation of very long-chain fatty acids causes membrane instability and myelin breakdown. Adrenocortical cells depend on lipid handling for steroid hormone production. In these cells, very long-chain fatty acids form lamellar inclusions that impair steroidogenesis. This shared dependence on intense lipid metabolism explains why the brain white matter and the adrenal cortex bear the brunt of the disease. Case 6. A 3-day-old male is flagged on routine newborn screening. His mother has a brother with adrenoleukodystrophy. Which biomarker is measured in the dried blood spot to screen for X-linked adrenoleukodystrophy? Option A, plasma cortisol level. Option B, the very long-chain fatty acid ratio, that is C26 to C22. Option C, C26 lysophosphatidyl-choline, also written as C26-0-LPC. Option D, an ABCD1 gene mutation panel. Consider which marker is stable, measurable, and suited to high-throughput screening on a dried blood spot. The correct answer is option C, C26 lysophosphatidyl-choline. The screening method is tandem mass spectrometry performed on the dried blood spot. Affected males with X-linked adrenoleukodystrophy typically show a C26 lysophosphatidyl-choline level above 0.40 micrograms per milliliter. The normal range is around 0.23, plus or minus 0.09 micrograms per milliliter. A positive screen is not the final diagnosis. It must be confirmed with plasma very long-chain fatty acids and with ABCD1 gene sequencing. Newborn screening allows affected boys to be identified before any symptoms appear, which is the window where treatment works best. Case 7. A 6-year-old boy with X-linked adrenoleukodystrophy, identified through newborn screening, is neurologically asymptomatic with a neurologic function score of 0. His brain magnetic resonance imaging shows symmetric parieto-occipital T2 hyperintensity with a loss score of 3, and gadolinium enhancement is present at the lesion edge. What is the most appropriate next step? Option A, urgent referral for hematopoietic stem cell transplantation. Option B, begin Lorenzo's oil and recheck the magnetic resonance imaging in 12 months. Option C, start high-dose corticosteroid therapy to reduce inflammation. Option D, watchful waiting with a repeat magnetic resonance imaging in 6 months. Note that this child has early active cerebral disease on imaging, but is still neurologically intact. The correct answer is option A, urgent referral for hematopoietic stem cell transplantation. Early transplantation can halt the progression of cerebral adrenoleukodystrophy, but only if it is performed before significant neurological decline has occurred. This child fits the eligibility window precisely: a low score, a neurologic function score of 1 or less, and gadolinium enhancement showing active but early disease. The standard rule is to refer for immediate transplantation when the low score is 9 or below and the neurologic function score is 1 or below. The impact is dramatic. Early transplantation is associated with around 84% major functional disability-free survival at 2 years, compared with less than 10% in untreated cerebral disease. When imaging shows early white matter changes, you calculate the scores and you act quickly. Case 8. An 8-year-old boy with X-Linked Adrenoleukodystrophy undergoes a surveillance brain magnetic resonance imaging. The scan shows symmetric T2 and flare hyperintensity in a specific region, and this pattern is seen in approximately 80% of childhood cerebral adrenoleukodystrophy cases. Which magnetic resonance imaging pattern is the most common in childhood cerebral adrenoleukodystrophy cases? Option A, frontal white matter involvement. Option B, a cerebellar predominant pattern. Option C, a combined cerebellar and frontopontine pattern. Option D, parieto-occipital white matter involvement. Recall the classic location of demyelination in this disease. The correct